Now, so we had now introduced into the pelvis the renal vein, and behind the vein we had the renal artery. Is that clear? So you are looking at the structures who are entering or leaving the hilum of the kidneys. So now this whole thing collectively we call it as the hilum, and that has to face medially. Now let's go for internal structure. Let's make a vertical section. Now we are looking inside that what is happening in this kidney. So you can see here the pelvis of the kidney. If you approach posteriorly, there are certain areas, and these are the receiving channels, and we call them calyces. And primarily, please be focused on this picture. We had an upper calyx, a middle calyx, and a lower calyx. So these are the major calyx, and then they have minor calyces. Minor calyces are many. So we had minor calyces, they join to form major calyces, and these major calyx, they are draining into the pelvis. They are making the pelvis, and pelvis is connected to the ureter through a point which we call it as PUJ or UPJ, and that means uretero-pelvic junction. This is a clinical use term, UPJ or PUJ. So that is a famous. If someone says this is a case of PUJ, it means there is an aberrant vessel, his pelvic ureteric junction is narrowed, and there is an element of hydronephrosis and all those things. So PUJ is a clinical term. Yes, Hariri. I cannot hear you, my dear. Shh. Guys, apparently we are looking at the kidney anteriorly. Is that fine? Aberrant vessel. Now, the minor calyces are joining and making major calyces, and we have three major calyx, upper, middle, and lower, and they are entering into the renal pelvis, and renal pelvis continues as the ureter. Now, in between we have these projections, these pyramid-shaped structures, and then now this outer core of the kidney under the capsule, this distance, this area, it determines the health of the kidney. Between this green line and then this outer capsule, this area, this thickness, the thickness of the cortex is the point. We do ultrasound for someone who has stone disease. A report comes, the cortical thickness is so and so. So doctor will come to the patient and explain to him, look, your kidney is almost gone. So what is the criteria? Why is saying your kidney is gone? Because the thickness, and thickness indicate the presence of nephrons. So if the nephrons, number of nephrons has been reduced, the nephrons have been diseased, so we have less nephrons. Less nephrons, less filtration. Less filtration, less functioning. Less functioning leads to non-functioning. So this kidney automatically goes into, this kidney will become small, non-functioning kidney, so there is no need to operate on that kidney. If it's not causing any pain, if it's not causing any problem, leave it as it is, and we call it autonephrectomy. What is nephrectomy? Nephrectomy means removal of the kidney surgically. And this autonephrectomy happens if kidney goes in failure because of any reason. It could be a calculous disease, a stone disease, or some other pathology. If a kidney goes diseased and ultimately the cortical thickness is lost, there is no cortical thickness, you can say simply this is a hopeless case. Okay, we can go for a surgery, but outcome will not be there. Don't expect after this surgery you will retain your things back. Now it has gone to an irreversible change. We cannot revert the process. Now you have to live with one kidney, and people can live with one kidney. Yes, Kanan?
Doctor, what happens if we don't
Nothing, it shrinks down and it stays as a vestigial organ. There is no usage, no function, it's not doing, unless this kidney starts troubling you. Unless there start pus formation and this and that, then you have to remove it. Otherwise, autonephrectomy, leave it alone. Don't touch it. If you want to make money, go for it. People do that. But there is no indication for that.
You said the thickening of the cortex determined the kidney.
Yeah.
The unhealthy kidney should be more thicker.
Guys, listen to him. He may have some valid question. Don't underestimate him. And you may have this similar question in your exam, and then, oh, we don't know the answer. Yes, my dear.
The unhealthy kidney will be thicker?
No, unhealthy kidney, this thickness will be reduced. Maybe this capsule will reach up to this level. So you will not find, even, in the lab, in the evening lab, we will give you some, this sheep kidney, kharoof kidney, and you will see, you will look for this thickness. It is very nicely visible there. You can look into that matter.
What about the large?
Huh?
The large thickness.
In large hypertrophy, it is not causing any issue. That's for some other reason. Now, what are these? So this part is known as the cortex, and cortical thickness is very important for well-being of a kidney. And we are blessed with a pair of kidneys. Now this part is known as the medulla. Within these green lines, we call it the medulla. And then this medulla has these red pyramid-shaped structures, and these are known as the renal pyramids. Is that clear? They are surrounded with these green dots. Going further, now this whole thing is given a name, and that is the renal lobe. Got it? So this part, the cortex plus the medulla, cortex plus the pyramid, collectively is known as the lobe of a kidney, renal lobe. And be reminded, our kidney starts its journey as small lobes, lobules. They fuse, and then there are around 12 lobules. They come together, they gel together, and then we have one homogeneous kidney. In the lower animals, if you take a kidney of a cow, you will see there are lobulations, there are rounded structures. So then in the lower animals, these lobes have not been fused, so you can see them differentiating. They are not separate, they are gelled together, but on their external appearance, you can see these small rounded thing. So those are the lobules of the kidney. And in human kidney, these lobes, they gel together, they become one substance, and the outer surface becomes smooth. But primarily, we have these, yes?
So doctor, there's a problem with a portion of the kidney. You just remove the lobes or the whole kidney?
My dear, if someone has, now first you have to determine what type of problem. Because there are various categories. Like, let me quote him. He put a right question. If someone has a stone here, look, I'm talking an old day story, when there was no advent of endoscopic surgeries. That was the era. People used to give this big incision for this small kidney to take it out and all that. Now that era is gone. Only 2% of the cases we open up someone. Now we just do endoscopically, and endoscopically what we do, the hole is not bigger than your pencil. Look at your pencil size. So this thick hole is just in the back, and through this hole you go to the kidney, you cut it, you remove the stone, you clean up things, you repair it, and then you get out, and at the end, person cannot see where is the cut, where is the suture, where is this and that, nothing is visible. And this is the last version. Before that, you have sound waves, patient is just lying down before going to office, he comes for a session, the shock waves are hitting, stone is being powdered, and it is being cleared by the urine. And then, after this procedure, he is going to joining his office, same day. He can go to his work. It's that easy. And he may need to visit twice or thrice in a month, and that is it. The stone is gone, there's no stone left, nothing behind. Now come for different pathological pattern, different diseases of the different thing and that need. But you said it's, I'll come to you, Sheikh, just wait, let me complete that. So if someone has a cancer here, now if this cancer is small, what is the rationale to remove the whole kidney? Because any cancer in the body has stages. Stage 1, stage 2, stage 3, stage 4. Stage 4 is usually the last thing, where you cannot offer anything. You do something or you don't do something, you know he's bye-bye. Now, stage 1, the best option, throw him out. Not the person, the part of the kidney, not the whole kidney. So chop this much kidney, the rest of the kidney is functioning. So why you are throwing the whole kidney? Only take out that much chunk which has disease. But before doing that, you have to evaluate the full kidney. That is, the disease is confined to this organ or the disease has spread it out. If the disease has spread it out, then you remove it or you don't remove it, you are not making a big difference. Getting my point? Yes, Sheikh, what was your question?
Is it possible for the stone to get stuck in the ureter?
My dear, yes, it happens a lot. I have a full session where I'll have an LGD with you on urolithiasis. It's not visible on your schedule at yet, but it will be. I'll probably put it for coming Sunday morning. So there will be, and I will bring the clips. I will demonstrate some of the procedures for you, and there you can see how we do it. Yes, sir.
Doctor, for autonephrectomy, do you remove the ureter as well, or only the kidney?
Why we need to remove the ureter?
Because it will be hanging.
No, my dear, we have a suture, we can put one small suture enough. We have enough suture. Throwing in the trash, we can put one, and there is no need. Like, when we touch on ureter, I will tell you how it is stuck. Otherwise, we don't put, okay, put some clips to my ureter is falling down. It's not happening. Okay, is this clear so far? No, it's not liver. Liver is the organ which regrows. Kidney usually not. Now, going further, so renal lobe is what? Renal pyramid plus overlying cortex. That is known as the renal lobe. Now, in between these, there are these sinuses, this area. So these are known as the renal columns. Clear? And now this tip, that is known as the papilla. Renal papilla. And renal papilla, as you can see, this is the major outcome where all the collecting ducts are secreting, are pouring their secretions to the minor calyces, to the minor calyx. And then this minor calyx, they join to form major calyx. Major calyx join to form pelvis. And pelvis continues as ureter. Ureter goes to the urinary bladder. And bladder continues as urethra. And from urethra, the urine goes to external urinary meatus. This is the pathway of the urine. Someone may ask you this question in OSPE, track the pathway of urine. So then you have to answer like that. I will explain it later, don't worry. So now, what I have highlighted, the whole of the calyceal system. So this is pelvic calyceal system. Well, there are certain other terminologies I'm just using which are necessary for beginners. I'm not putting up here so many fine details which are being required if you are practicing urology. Apparently you are beginners, you are level 1, so just information will go with that much depth. So this part which is being highlighted now, that is highlighting the pelvic calyceal system. So you are looking at the pelvis and you are looking at the minor calyx and the major calyx. Is this clear? Yes. So now we call them the minor calyces, and these are the major calyx. Is that fine? Yes. And this we call as the renal pelvis, and this we call as ureter. Fine? Pelvic-ureteric junction is somewhere here. Clear so far? Any term which is not clear? Yes, Ali. This yellow? The pelvic calyceal system. Pelvic calyceal system, a system which comprises of pelvis and calyces. Because singular is calyx, plural is calyces. Right? If we write individually, we can write calyx. But if we are putting them together, they are calyces. Clear? Now, what is this?
Sinus.
Renal sinus. Very good, Mohanna. Now, come to reality from an image. Image to image. That was schematic, this is real. So let's look at it. I hope you know it. You can answer most of the things. You are looking at suprarenal gland who lives above the upper pole of the kidney. And that is being compartmentalized. That is being separated. So once we remove a kidney, we have to prevent. If you take out suprarenal, taking out suprarenal is major undertaking. Doing a suprarenal removal surgery, patient should go in crises and all that because so much hormonal things have been regulated by this adrenal gland, adrenal medulla, so many important factors. So when we are taking out kidney, we should be preventing this suprarenal to stay in its place. And there you can see pararenal fat pad is separating these two, and we learned it yesterday how rich is this organ, but we will be discussing it in year 2, not here. So you can see the upper pole, lateral border, medial border, and there you can see the outermost, the most anterior structure at the hilum of the kidney is the renal vein. Then we have the renal artery, and then we have the most posterior structure is ureter. How we differentiate the ureter? If we hang a kidney with an intact ureter, the ureter is found hanging down. Yes, Umar. Renal sinus is a potential space where there was an angulation of the calyx and the substance of the kidney. Sheikh, you had a question. Did I answer your question? Thank you. Any question from here?
What's behind the artery?
Behind the artery is the ureter. The pelvis, behind the artery is the pelvis, which continues as the ureter. Clear? Yes.
Is the gland enclosed in a kidney layer?
This gland is not enclosed in the, is separate.
The fourth layer you mentioned, they are between.
My dear, these 4 layers, only one layer, the capsule of the kidney is a complete layer. All other 3 layers, they are not complete. They are not coming all around the kidney. They are partially covering the kidney. Yes, Father. He asked the same question. He stole your question. Don't do it, Father. So now, here we are looking at the kidney with its blood supply. And we are looking at the renal artery, suprarenal, and then the renal vein and how things are going. Let's pass. And there the same image, you can see that how capsule is delicately adhered with the substance of the kidney. You are looking at the right and left kidney. But remember, this is not right and left. This is the anterior view and this is the posterior view. Why I put it here, you can see that in the posterior view, the pelvis is the most posterior thing, with now it comes anterior because we are looking from behind. And if you look from the front, we can see the vein is the most anterior structure. And from the back, the renal pelvis is the most anterior structure. Is that clear?
Clear enough.
Going further, yes. Now, a partial chip has been removed to show you the structural arrangement. You can see that how the renal artery, it divides into segmental branches. We'll talk about it today. And there's a specific, and you can see how this cortical arteries and how there's a mesh of arteries is being embedded throughout the cortex and throughout the different areas. And you can see the calyceal system, the pyramids, and how the pelvis, and how rich is the blood supply of these adjoining areas. This is the same image, partial and the complete. We have seen about it, we have talked about it, we know about it. Am I right?